Hello friends, today we will be sharing an interesting case of tackling an intumescent cataract in a young patient. This case is a 20-year-old young man who presented to us with total loss of vision in the right eye. There was no history of trauma or any other leading clue. His lamp showed the anterior chamber was quiet and there was presence of intumescent cataract. Rest of the ocular examination was within normal limits. Patient had a uveitic workup which was also within normal limits. Patient was taken up for phacoemulsification. The biggest challenge in this case is to avoid Argentinian flag sign and ensure in the bag aisle placement. Now let's see how the case went. So as we can see, this is a classical wide intumescent cataract. Here we see initial incisions being created and capsule being stained with trypan blue. Anterior chambers was formed by high molecular weight cohesive viscoelastic sodium hyaluronate. Capsular opening was initiated using cystitome in a crescentic manner so that to avoid sudden vertical rip-off that can sometimes happen. As the flap is being manipulated to create the opening, the capsule was found to be very elastic. Other end of the capsular opening was then used to create a flap to complete the capsular access from the other side. That was also difficult. Cataract decompression was done using a cannula and an attached syringe in order to reduce the intralenticular pressure. So an Entrada forceps was taken and the flap was held and CCC is completed in a very controlled fashion. The initial idea was to create a small rhexis and then to enlarge the rhexis towards the end of the procedure. So we have got a reasonably around 4 millimeter rhexis through which we should be able to remove the cataract easily. Now, as we started doing hydrodissection, we noticed that the lens matter is very loose and it was very easily removed by INA probe of the phacoemulsification system. A three-piece hydrophobic acrylate lens was placed in the bag. Next, we enlarged the capsule rhexis opening by giving a small nick in the anterior capsule at 2 o'clock position. And then, with the help of microcapsular rhexis forceps, this flap was caught hold and the capsular rhexis was enlarged to the desired size. So as we can see now, this capsular rhexis is more or less adequate with approximately 5 millimeter in diameter. And this is how the eye looks towards the conclusion of the surgery. Post-operatively, the patient did very well. There was no reaction in the eye and he regained his vision from the next day itself. Thank you for your attention.